And here we are in week 6. We're going to be doing chapters 17, 18, and 19. This first lecture is going to be part A of 17, the basics of neurodegenerative disorders with an emphasis on Parkinson's. We will follow up with Alzheimer's and multiple sclerosis in part B. The big thing that the three diseases that we're going to talk about, but any of the neurodegenerative disorders, is that they all involve a progressive loss of function or death, usually, oftentimes the latter, death, of a given population of neurons. So for instance, Alzheimer's disease tends to dominate in certain areas of the brain. Parkinson's disease, certain areas of the brain. Prion usually is a little more diffuse. That's like the Jacob-Creutzfeldt disorder, also known as mad cow disease in cows. Amyotrophic lateral sclerosis. We can even get into the peripheral nervous system. Diseases like polio are neurodegenerative disorders. So it just depends on where the neuronal death is occurring, and that can then lead to loss of function and then a diagnosed type of disorder. While we do have certain specific causality for certain types of neurodegenerative disorders, like for instance, genetic factors and so forth, it turns out that all of these disorders to one degree or another are multifactorial. That is to say, there are often genetic factors, like for instance, there are family history associations with things like Alzheimer's or Parkinson's and so forth. But you can and do get environmental factors that play in. The type of work and what you're exposed to, whether you're under a lot of stress, either from psychological stress or from environmental or behavioral stress like smoking or exposure to heavy metals and so forth. All of these things can contribute to inappropriate protein folding, inappropriate protein modification that leads to either non-functional or pathological protein situations that then will lead to loss of function and death. But it's the same story. When you look at neurodegenerative disorders, it's just a matter of neuronal population, because the neurons are then responsible for the various functions in the central nervous system. Our three diseases that we're going to focus on, and again, all of these diseases here are forms of neurodegenerative disease. Our three that we're going to talk about in this lecture specifically include, in order, Parkinson's disease, talking about the story of dopamine and how we treat Parkinson's. We're going to deal with Alzheimer's disease, which is fundamentally a cholinergic neuronal death in the brain, acetylcholine. And then multiple sclerosis, which is an autoimmune disorder. We see a number of diseases that affect the body in an autoimmune fashion. And so not only are we going to use this in terms of neurodegenerative disorder, but we can use it as a model system for other types of autoimmune disorders involving thyroid or other tissues in the body. We're going to get started as in terms of the way the book presents this with this one is a relatively specific neurodegenerative disorder, specific in the fact that it occurs in a very, very specific location in the central nervous system, and that's called Parkinson's disease, or sometimes you see it in the possessive Parkinson's disease. Parkinson's disease is defined by loss of coordinated movement. Leading to issues like, for instance, what we call hypokinesia, that is to say, decreased movement. They move slower, they move more deliberately, they don't have a motion flow, if you will. It turns out that a lot of our complex and fluid motions are actually a series of feed-forward reflexes. For instance, if you see somebody going to spike a volleyball, you see them run up and then they jump and then they move their arms in a certain way. That's a lot of that is feed forward, and there seems to be loss of that in Parkinson's disease. So what we see is absence or poverty, lack of control, Certainly we see rigidity and tremor. That's a very common one, but the slowness or loss of ability to move, um, uh, and so forth. A lot of those feed forward type learned, in many cases, learned body movements get lost in Parkinson's disease. And it's one thing to think about Parkinson as a clinical condition. It's another thing to see the devastating impact that Parkinson can have on truly extraordinary people in some cases. Muhammad Ali was not only an amazing sports figure, he was also a cultural leader and a pioneer in representing minorities in the political infrastructure. But who was a guy who was amazingly talented. He won a gold medal, and then was a famous boxer for many years. He suffered from Parkinson, and it was believed it may have been due in part to his to many receiving blows to the head in many cases. So you can see, it wasn't just age that he lost the ability to speak. And he was seriously debilitated in his later years due to that Parkinson. So it has an extraordinary impact on occupation. And this is dating a little bit, but Pope John Paul II suffered from Parkinson's for many years. If you're old enough to remember him, you could see him degenerate in real time. Somebody who tried to hide his Parkinson's initially, Michael J. Fox, a famous actor and physical comedian. He was a gifted physical comedian. He could fall down. He could do these amazing things as a physical actor, but began to lose it progressively. He suffered a young onset. Um, Pope John Paul was more of an age onset, but Michael J. Fox was more of a genetic onset because his occurred in his early 30s and 40s. Most, but not entirely all neurodegenerative disorders are chronic and progressive. Especially when it comes to progressive. There are examples of where a disease which progresses but then stabilizes for some reason. A famous example of this was the astrophysicist Stephen Hawking. He had relatively aggressive progression in his disease in his early 20s that then stabilized, and he actually attributes his fame and success as an astrophysicist to being basically imprisoned inside his body. It allowed him plenty of time to think, is what he said. An extraordinarily optimistic way of looking at what was a major debilitating disorder. In the case of Parkinson's, what we see is that progression. I don't know of any examples of stable Parkinson's. It usually is almost always progressive in some way, but it begins as mild symptoms, maybe a mild tremor or that sort of a thing. If they're involved in a very, very fine level of occupation, like for instance, let's say they're a watchmaker or a surgeon, or they like to paint those little lead figures that you use in Dungeons and Dragons and that sort of a thing, they may have trouble doing that. Stage two, what we begin to see is a spreading of the disorder. It's no longer limited to maybe one side. It may not affect them overall, but yet they are moving slower. Their posture is beginning to change into what we call the Parkinsonian shuffle. Stage three, they are much slower. They have lost a lot of those feed forward reflex mechanisms that allow for graceful and sort of dynamic motion. It's moderately severe, so a lot of what they were able to do before, they probably can't do anymore, and they're relegated to relatively passive occupations. So here's an example of that Parkinsonian shuffle. They just don't have the ability to extend and do those feed forward motor reflexes. It may involve rigidity, but it also involves a fluid motor coordination. Stage four, What we see is severe symptoms. They may only be able to walk a very limited amount. It's affecting their overall health now because they just can't exercise to any significant degree. They have lots of rigidity, different types, the cogwheel and so forth, and they're usually unable to live alone. They require assistance to eat. Require assistance. They certainly can't drive, so they're unable to fend for themselves. And in stage 5, they are completely invalid. They just can't function at all. They're basically bedridden, and it's a truly unfortunate outcome in these patients. A few key features of Parkinson's disease that you should understand going into the different types of therapy. We are losing or having issues with neurons in this area called the substantia nigra, the black substance. That's because these neurons tend to have a pigmentation to them and involve dopamine signaling. Now, it's not necessarily limited to dopamine. It's actually an imbalance between dopamine and acetylcholine that we're seeing, and that'll play into some of the therapies that we see. But we lose function in these neurons, particularly dopamine is more common. And we see, as a result, we see loss of coordinated muscle movement, loss of feed-forward type muscle behavior, movement behavior, slowing, and so forth. We might see rigidity. For instance, this is a form of what's known as cogwheel rigidity, as opposed to, say, lead pipe or plastic rigidity. We're not here to discriminate between these two. It's a little bit hard to see in this image, but nevertheless, there are different kinds of rigidity that have been documented. We also have, again, slowing or loss of movement ability altogether, coupled with things like tremors. This happens to be called a pin rolling tremor in the hands, very, very common in Parkinson's patients. But Parkinson's can and does progress, as we mentioned in the earlier slides. It can lead to posture issues, inability to walk and gait changes, but may lead to issues with autonomic issues because we're dealing with dopamine. Dopamine is also involved in the autonomic side of the equation and can also see dementia because we're also dealing with acetylcholine. Because what we are seeing most often with Parkinson disease is an imbalance of dopamine and acetylcholine activity in that substantia nigra region, also known as the extrapyramidal region of the brain, the goals are fairly straightforward. Either to restore dopamine signaling in that area or sustain dopamine signaling in that area, or to dial down the other side of this. Think of a teeter-totter. So we want to get dopamine back or we want to reduce acetylcholine. Having us in balance is a way of alleviating symptoms. It's not curative. Mostly here what we're doing is alleviating symptoms by restoring dopamine or reducing acetylcholine. If it was truly curative, what we would be able to do is restore those neurons in those pathways. This figure at the top illustrates the point I was making in the previous slide about the fact that the therapies that we have for dopamine are merely ameliorative rather than curative. They reduce symptoms and stave off progression rather than curing. Under normal situations, we would have a dopaminergic neuron that's doing its thing, but what happens is those neurons seem to die for some reason. Either they're poisoned or they have some issue in their metabolism that causes them to die, and so we lose that part of that regulatory signal. Here's acetylcholine. And again, it's a gated type system. What it is to say, this thing dials down GABA in this situation. It's hyperpolarizing this neuron. If you don't have that hyperpolarizing, you will end up getting inappropriate signaling, and that's part of what's going on. And we have two classes of drugs that we group them. One are type 1 drugs are the ones that are meant to increase the dopamine signaling, trying to increase this right here to dial down this GABA. And so we have the precursor of dopamine. It's known as levodopa or L-dopa. We can also have a drug that stimulates dopamine. This is usually more functional early on in the disorder before the neural population has depleted. And then we have some that are called that are other dopamine analogs. We can't give dopamine straight away because it can't penetrate the blood-brain barrier, and so you can't get it to the area that it's needed. So we have to give either an L-dopa or a dopamine analog. Over on the type 2 side, these are meant to dial down the acetylcholine, and so we have some drugs that we might have seen before, like particularly diphenhydramine that we might have seen in the autonomic system. But again, these ones are meant to inhibit the cholinergic signaling that's occurring in and around the substantia nigra part of the brain. Although I have mentioned the acetylcholine side of the equation and the balance, that is a relatively tricky strategy to try to go after acetylcholine because of its widespread use throughout the neuronal system. We will talk about some inhibitors, but really the frontline therapies are all going after dopamine. They're all trying to upregulate dopamine. So levodopa is one of those frontline drugs where, or L-dopa, where we can deliver it and get more dopamine in living neurons. If the neurons are gone, it's not going to help a whole lot. In any case, levodopa is brought in, it's converted to dopamine, and then dopamine is released during signaling. Now, dopamine is just like acetylcholine, it's just like other neurotransmitters. It will be released out into the synapse, and then one of three things can happen. It can either be brought back into the presynaptic neuron for recycling. It can be degraded by enzymes, like for instance MAOB, or it can diffuse out of the synapse. And so those are going to be some of the targets that we're going to go after. When L-dopa is brought into through the blood-brain barrier through carriers, it's taken up by the neuron, it's turned into dopamine. We can give L-dopa, that works well, but we may also want to bump it up. We have drugs called carbidopa that I'm going to discuss a little bit later that help deal with the side effects because dopamine is not just involved in fine motor regulation. We could also prevent L-dopa from being metabolized. So we have L-dopa here going in. We can also inhibit enzymes that break down L-dopa, like the COMT enzyme. It's an oxidase of some kind. They just call it COMT because it's easier to say. We might inhibit COMT so that more L-dopa can make it to those neurons. We can also have dopamine receptor agonist, sometimes just shortened as dopamine agonist. So if you see dopamine agonist, think dopamine receptor agonist. These will interact with the D1 or the D2 dopamine receptors and cause signaling down here. A little bit problematic. They haven't come up with really effective drugs. I am going to talk about one that sort of works, but it's really it's only going to serve as a precursor, hopefully, for better drugs in the future. And then we have the uptake side and the intercellular, I should say, degradation. So monoamine oxidase B is an enzyme that we find in the synapse that will degrade dopamine. It also is present inside the presynaptic neuron and can degrade dopamine up there. So we have these MAOBs these inhibitors that can increase the half-life of dopamine in the synapse, but also increase the availability of dopamine in the presynaptic neuron. And then lastly, we'll talk about amantadine. It's a reuptake inhibitor, among other things. So by keeping dopamine in the synapse and not being reuptaken, you extend the length of signaling in the synapse and thus, in theory, increase the amount of signal that occurs downstream. So several targets here. We're going to go through a few of these drugs, going after these different targets and talk about things that they have in common and what makes them different. There are several drugs out there that are used to increase dopamine levels. For purposes of this lecture, we're going to focus on levodopa and carbidopa rather than go through all the different ones. I've shown you some of the targets, but most commonly we see these, and if we start to fail, then you might start to see some of these other drugs showing up. So here's L-DOPA. It's a precursor of the catecholamines. All catecholamines are originally derived from the amino acid tyrosine. It's an immediate precursor and is easily converted into dopamine with just a slight modification. There are different types of dopamine receptors. We have D1 and D2, and the agonists that affect those can be specific for one or both. This is just another figure showing you the same thing. So L-DOPA is a metabolic precursor of dopamine. So levodopa is taken up by dopaminergic neurons and can be quickly converted to dopamine. It can penetrate the blood-brain barrier, so it is effective as opposed to dopamine, which is not able to penetrate the blood-brain barrier. Initially, it will be or should be quite effective at increasing the dopamine concentration in those synapses. The problem, though, is that this is a progressive disease. Dopaminergic neurons either fail or are lost altogether, and so we have less and less ability to convert that L-DOPA in those neurons. On the way, we see a couple of things that are described. It's like tolerance. We are much more familiar with this in terms of addiction. It's what we call a wearing off effect. That is to say that the effect of the L-DOPA will go away before we are capable of administering the next dose. What I mean by that last phrase is that if you give too much, you're going to see ancillary side effects, whether they're in the autonomic system or triggering other neurologic pathways. And so what you see is a loss of efficacy, but not a loss of toxicity or adverse side effects. The therapeutic index, if you will. And we also will get this, what's known as an on-off phenomenon, which I will describe in the next couple of slides. In early Parkinson's, what we see is a relatively nice clinical effect when we give levodopa. We administer it in about an hour or so, or even a little bit less. We will see that beneficial effect, and we continue on through close to 8 hours without either loss of effect or add-on effect, if you will, where we start to see inappropriate motor functions or loss of existing function due to side effects of dopamine. But what we see is this wearing off phenomenon where we give as we increase the amount of dopamine or L-DOPA that we give, what we end up with is we start shooting through that clinical window into the dyskinesia region, and we also lose efficacy sooner. So that's the wearing off phenomenon. When we get to advanced Parkinson's, what we see is an on-off. We see going up into the dyskinesia where we have no efficacy whatsoever. And what we get are these on-off situations where we have a therapeutic window that we reach for a short period of time, but then we quickly lose it. And then it comes back for a brief period of time, and then we lose it yet again to lack of efficacy. So it's again, this is on-off phenomenon and the wearing off phenomenon shown here. When we look at adverse effects, the first thing you could think about dopamine is that it shares a structural similarity to epinephrine and norepinephrine. It's a catecholamine. Dopamine also is not just relegated to the substantia nigra. We see dopamine in the gastrointestinal tract, which would explain nausea and vomiting. If we give L-DOPA in some cases, we see dopaminergic and or adrenergic receptors in the vasculature, so we could see hypotension there. And we do have adrenergic receptors in the heart. So if the dopamine is acting as a mimetic for epinephrine and norepinephrine, we could see arrhythmias. More commonly, though, what we would see are what are called dyskinesias, and that gets back to that on-off phenomenon that I talked about earlier. If dopamine begins triggering involuntary movements, that's known as a dyskinesia. So what happens is you might have alleviation of tremors and so forth, and then you shoot through the clinical window and you get into the dyskinesia window. Now you're introducing new involuntary movements. Psychotic effects. Dopamine is active in the neurologic system, in the central nervous system, above and beyond the substantia nigra, particularly when it comes to reward pathways. Every time you pick your phone up to look at that text message or social media, TikTok, you name it, you're getting a little puff of dopamine in your reward centers of your brain. And it is not unknown that people who go on L-DOPA therapies develop very, shall we say, dangerous levels of addictive behavior. You can also have sedative effects, agitation or delirium, or other types of neurologic effects. So dopamine works around the body, and so the side effects we see are primarily due to the sensitivity of that area of the body to that elevated level of L-DOPA. One drug that is frequently administered with levodopa is a close structural cousin to levodopa known as carbidopa. Carbidopa has these slight chemical modifications, and it confers some very, very interesting activities. So if we give levodopa, particularly if we give elevated levels of levodopa, we see it getting converted to dopamine. So anywhere where you have the enzymes that, like for instance, this one right here, you will get dopamine, and that means side effects. Well, carbidopa is really, really interesting because it will block these enzymes and prevent levodopa from being converted to dopamine where it is present. It actually serves as a competitive inhibitor of levodopa. But what's really, really interesting about it is that carbidopa is normally ionized at physiologic pH. And when you have an ionic charge, that means you can't cross membranes readily. And so blood-brain barrier is a membrane, so it will not inhibit the formation of dopamine in the CNS, but it will inhibit dopamine in the peripheral tissues, particularly the GI tract. So it will reduce the cardiovascular and GI side effects of L-DOPA and will potentiate the efficacy of L-DOPA. So we can reduce the dosage, prevent wearing off effect, preventing the on-off effect. So by using lower doses, you're less likely to induce side effects, and you're less likely to have that acclimation to dopamine. On the receptor side of the equation in the dopamine signaling, we have a drug that is known as bromocriptine. That'll be our poster child. There used to be another drug called pergolide, which was a D1, D2 agonist, but it's been withdrawn because it has side effects in the cardiac realm. So we're just going to talk about bromocriptine here. It's a D2 agonist, and it's a mild D1 antagonist. So it's sort of a D2 specific. It has less overall efficacy than L-DOPA. It's not as effective. We would use it in place of L-DOPA if for whatever reason the patient is fully resistant. They won't get the on-off phenomenon. So if you have issues with on-off, you may be able to go to bromocriptine, but there is the potential for exacerbating symptoms because again, you're stimulating the dopamine pathway. So if they already have dyskinesias, it may make them worse. So it's not exactly a replacement. In any case, the side effects: nausea, vomiting, confusion. So GI and neurologic side effects. And while the drugs that we have right now are rarely used, so these dopamine receptor agonists are not used much as we would seem, nevertheless, there is promise here that if we could somehow find more effective drugs that have fewer side effects, more specificity, there is therapeutic promise. The good things about these agonists, if they do work, is that they don't need to be metabolically converted, so you don't have those extra steps. They have better kinetics in some cases than the levodopa. They don't depend on specific transporters and so forth, and they last longer. So there's great therapeutic promise here. It's just that it hasn't yet been realized, and at this point, the dopamine receptor agonists are rarely used. So some other therapies out here that are sort of second line when levodopa starts therapy is not working properly. We have the monoamine oxidase B type, the type B inhibitors. These will prevent degradation of dopamine in the synapse, but are also present in the enzymes are also present in the presynaptic neuron, and thus will increase the amount of dopamine available for recycling. We also have the COMT inhibitors. The COMTs ones that are out there. It's not listed in this one, but that's also another possibility. We have the anticholinergics, and we'll do a little bit of talking about that. And then we have amantadine, which among several things that it seems to do, one of the things that it seems to do is block the reuptake of dopamine. So it's a reuptake inhibitor, but it also seems to have some other functions. We're going to talk a little bit about these mechanisms in a little more detail and then get you to the drugs. Monoamine oxidase B inhibitors are drugs that are in the larger category of MAOIs, monoamine oxidase inhibitors. These ones are more specific for the B type of monoamine oxidase that prevents dopamine from being metabolized in the presynaptic neuron. So it's going to inhibit the degradation of dopamine. There is evidence that it also is present out in the synapse or in cells close to the synapse. So monoamine oxidase, the basic function is to reduce the population of dopamine. It is not a primary therapy. So what we do is we use it as an adjunct like carbidopa to increase the efficacy. But when we increase the efficacy and by increasing the concentration, that's just equivalent in some cases to giving more drug. Maybe certain side effects are ameliorated, but you're still going to have more dopamine out there. And so it may reduce the off time in some of those on-off syndrome situations, but consequently it may increase inappropriate motion due to the excess dopamine. So there are some risks. Anytime you upregulate dopamine, you increase the possibility that dopamine is signaling too much. Okay. May have some neuroprotective properties. That's yet to be determined. It's unclear at this point. It may just be for the fact that this is an oxidase and it's oxidizing stuff. So by not oxidizing stuff, you have fewer reactive oxygen metabolites, but who knows? So our poster child drug for MAOBs is salicyline. What it does is it prevents the MAOBs from functioning, so the dopamine is not oxidized into dopac and hydrogen peroxide, and that may be where we have the issue of oxidative damage. That's where that neuroprotection is going on. Is that by blocking the creation of additional hydrogen peroxide, you're in a way protecting the neuron a little bit. So it's an MAOB inhibitor, keeps dopamine from being degraded, more dopamine, more signaling, and some neuroprotection on the way. Amantadine is this cool little double ring or like structure. It's very three-dimensional. Again, the primary mechanism is that it seems to block or reduce the ability of the neurons to reuptake dopamine. So that means more dopamine is present in the synapse for longer periods of time, longer half-life. It may also trigger release of dopamine. So there is a secondary function that there's more dopamine secretion with amantadine. It's frequently used in early stage Parkinson's in conjunction with levodopa, or if levodopa is problematic, the dopamine agonist. So it's a nice additional drug to help augment the function of the frontline drugs. And it does, improve symptoms, but it's not the curative, if you will. Again, none of these drugs are truly curative. Just a couple of slides about the anticholinergic therapy. Again, as dopamine is lost, we get over secretion or over signaling from the acetylcholine side. So what we're trying to do is achieve that balance without going overboard, if you will. We do know that part of the justification for acetylcholine and this balance is that when we have neurons that secrete acetylcholine that are downstream of dopaminergic neurons, when they receive dopamine and they have these D2 receptors, they will slow down their release of acetylcholine. So that's part of the justification, if you will. So benzotropine, trihexylphenadil, uh, those are the two drugs. Again, they're not as effective. They tend to have side effects. They may probably, like I said, the tremor here is more than anything, but not any of the neurologic or GI type symptoms. Um, so again, not so, just another, we're still working on this side of the equation because they're just not specific enough. So here's a breakdown of the two types of anticholinergics, benzotropine and trihexyphenidyl. Again, I'm not going to worry about one or the other. The main thing here is that they have these, if you are dealing with acetylcholine, you're going to get autonomic issues. Okay, so moving with the anticholinergics, understand that it's a balance between dopamine and acetylcholine, and that you could go after to try to dial back acetylcholine, but you may end up particularly causing sympathetic situation, because if you give a patient acetylcholine, they're going to see more parasympathetic symptoms. So by dialing back the acetylcholine, you're going to see an upregulation of sympathetic situations. The book does want to talk a little bit about neuroprotective drugs, and we already talked about amantadine as sort of being in that situation. The reason amantadine is in there is because it's helping reduce the amount of hydrogen peroxide that may be created. But two that I want to highlight for you, one is a drug that's actually used in diabetes. It's metformin. Not entirely understood how it's working. There seems to be some neuroprotective effect involving some what we call oligomeric proteins that are toxic. These are either peptide fragments that are caused from protein misfolding, that sort of a thing. There's too much of this stuff that's in the cell and it's not been metabolized. Maybe metformin facilitates the detoxification, if you will, in neurons. It's interesting stuff. Very, very cutting edge. The other one is also kind of fun. It's called resveratrol. Resveratrol is actually found in things like red wine, which is great. Okay, or certain types of green leafy vegetable products, or fermented products in particular, like kimchi or sauerkraut and things along those lines. So resveratrol, again, with a number of different mechanisms, seems to be a neuroprotective and prevents the cells from dying in the first place. So these two drugs are getting after the actual problem of cell death rather than just trying to deal with the symptoms of dopamine deficit. This is sort of the standard of care, and I would like you to think along these lines. I may not be doing this as well as I'd like, but I always am desiring to bring your side of the equation to pharmacology. Understand that these patients are going to progress. And so you understanding what drugs they're going to be taking at certain times and then understanding where they might go with those drugs is going to, I think, to be helpful information. So when early on, if they're young patients or if they have mild symptoms, they might do levodopa, low dose, or they might have an MAOB or, something along those lines. But after about 5 years, about 50 of those patients are going to start to go into on-off syndrome, dyskinesia because of the time off situation. They become acclimated to dopamine, or it requires more dopamine to alleviate symptoms because the neurons are dying. So they're going to increase the doses. They might use augmentation, combination therapy. Nevertheless, we're treating symptoms at this point, and so they are going to progress. You try to do deep brain stimulation, and we're going to talk just a little bit about a project that UIndy is involved with. But again, where in this is anything about neuroprotection? Probably if we were going to do it, we would do it as soon as we have symptoms or in patients who are particularly high risk, known for early onset Parkinson's, family history, etc. But this is where all of this goes in pharmacology, is you understanding the drugs going on tailored to where this disease is going. So knowing how the diseases progress, what's going to happen in the disease, helps you to understand why they may be on certain drugs. Along those lines, I really like that section of clinical practice considerations for Parkinson disease and neurodegenerative disorders on page 286. Non-pharmacologic therapy to go along with what's going on here. You're going to be giving therapy to counteract the side effects or to augment the possible stimulatory effects of these drugs. And the classic example of this is this non-contact or type of boxing. These are all Parkinson's patients who are doing boxing therapy, and it has actually quite extraordinary capacity to reduce symptoms in early onset Parkinson's. It was actually featured on 60 Minutes. Leslie Stahl, one of the hosts of 60 Minutes for many, many years, her husband suffered from Parkinson's and was doing this boxing therapy. And one of our professors at UIndy was actually flown out to New York and interviewed by Leslie about this program. And it really works to slow down the progression of the disorder. So understanding the drugs, understanding when they're going to be prescribed and how the disease is going to progress, supporting for symptoms, getting good exercise and excellent nutrition are all part of the game here. But the more you can work with this, the stronger you're going to be with this. That's why I'm always trying to push you into those 4 E's: explanation, example, evidence, elaborate. So this concludes part A of chapter 17, and we'll come back with part B, where we'll talk about Alzheimer's and multiple sclerosis. Talk to you soon. Bye.